All right, I just want to give you guys some feedback on your case study for your patient with congestive heart failure who has a history of cardiomyopathy, an ICD placement 2 years ago, and then just had a catheter implanted. So a few notes I took. Overall, really, really good job on this assignment. Most of you caught that he does need to have a warm up and cool down. If that was an area that wasn't addressed, I did take points off because we've talked about that in both 2600 and now again in this class that a warm up and cool down is essential for patients with CHS to avoid post exercise arrhythmias. So great job. Most of you got that. Some of you did a great job about communicating with RN or other team members as far as cardiac rehab. That's a fantastic thing to put in the note. Just always make sure to document that, and then also document that you communicated with them as well. Good. Cardiac rehab is going to be twice a day. Normally, if possible, PT is going to try to get there. Some programs will have exercise physiology, cardiac rehab therapists, or nursing do the second time. So just know that that can be a little bit program dependent. I loved your descriptions about RPE. It was really interesting to get to a 13. Those of you that did it with running, it took you on average about 5 to 6 minutes to get there. Those of you that were walking, depending on hills or flat surfaces, it seemed to be between 15 to 25 minutes. We had a couple people try stairs, so that got there within 1 to 2 minutes. So just realizing that you are a fit group. So these numbers represent a more active, healthy group. So that just kind of helps you think about how long and what mode of exercise it might take for your patient to get to 13. And you guys did a great job of explaining what it felt like in your body when you got to an RPE of 13. The dyspnea index, the scale 0 to 3. I'm realizing now one of my slides said 4, so I apologize. It's 0 to 3. And then someone also noted that they found it was also called the 15-count breathlessness score, which does make sense too. So you may see it referenced that way. It's the exact same scale. We will talk about this week the Borg CR10. That is the variable, the Borg, where it's actually 1 to 10 instead of 6 to 20. You can use it just like RPE. Otherwise, you can use it as the perceived level of breathlessness from 1 to 10. Doesn't matter what you use, just know the cutoffs and document which scale you're using. Things like wheelchair follow. That was awesome. I saw a lot of you documenting that. It's really important in acute care to document any kind of assist, whether there was a wheelchair follow, even if you didn't use it, and any assistive device needed. So I know this is not a real patient, but just make sure that you're always including that information so that if I'm coming in the next patient or the next therapist, I know exactly what to grab, what this patient might need, how I can progress them. A few of you talked about sternal precautions. That's not needed in this patient. I didn't take any points off for that, but just realize that with the catheter placement, they don't typically have sternal precautions because the sternum was not opened. One of you used the Carbonin method and calculated heart rate based on 40% heart rate, so that's fantastic. This patient's not on beta blockers. You can use heart rate. RPE, though, is very easy. Very good thing to use in acute care, but good job for using that method. And a couple of you picked up on the diabetic side effects as well and thought about dehydration and the effects of hypo or hyperglycemia in your patients. Let me just see if there's anything else I want to talk about. Oh, one spot that was hard for a few people was talking about the reasons you would stop exercise. You all knew what, but it was the why that was a little bit harder. So if you don't understand the why to these, please go back and look at them because that's going to be imperative to lab, to the quiz, and just clinical practice. It's a good thing to understand what's going on with your patient and not just memorize numbers. So for example, with someone that starts to have angina and their chest pain's getting higher than a 2 to 3 out of 4 on the angina scale, why? Why are we concerned about that? Why would we stop exercise? Well, it's lack of perfusion, right? Chest pains happens when the heart muscle itself is not getting enough blood flow and not getting enough oxygen. So we're at risk of ischemia and infarction. So that's why exercise needs to stop to allow the heart to slow down and improve the perfusion. Things like blood pressure. Why are we concerned if the systolic blood pressure drops? One of you did a really good job of explaining that. I was going to just read this to you. So, Ciara found this, so kudos to you. But it says when the systolic blood pressure drops 10 millimeters of mercury or more from baseline, it can represent a left ventricular dysfunction, circulatory collapse, and/or onset of shock due to a myocardial infarction. A drop in blood pressure means the body's organs aren't getting enough blood. It can cause further cardiovascular problems, a stroke, and failure of other organs. Signs of a drop in systolic blood pressure to be aware of in Mr. T include cool, clammy extremities, dizziness, orthostatic hypotension signs, fatigue, and/or blurred vision. So that was a perfect answer to what I was looking for, just for an example of, yes, I want to know if systolic blood pressure is dropping, but why do I care? What does that really mean for this patient? So some of you did a fantastic job. Others, that's where points came off, opportunity to improve. But if you don't understand the different things that you identified, please go back and review those. I think that is all of my comments. Great job, you guys. If you have any questions about your grade or your score, you can set up a time with me. Otherwise, feel free to come to office hours sometime tomorrow, Tuesday, or Thursday. Have a great rest of your day.